So good afternoon, everyone. Thank you for having me here. I guess we're getting the slide presentation kind of going here. What do I hit? There we go. Awesome. Maybe it works. All right, that works. No, it doesn't. Spacebar. Oh. All right, we'll just go ahead and get started. I'm going to actually start with something that Jeff talked about as far as everybody working in collaboration and where we're at. I think you could kind of look at my position as part of that growth of all of us working together. I think a lot of you know me. I've been the Network Homeless Program Coordinator here in the area for a few years now, and I just picked up the role as being the Network Suicide Prevention Lead. Vision 6 is one of 3 networks in the nation now that currently has this built into the Vision office. And so I think that allows us to start looking at this from a more statewide perspective, enabling us to kind of work with state partners, government offices that medical centers aren't necessarily so able to incorporate and bring that in with. And you know, as I kind of start with this, when I was preparing this, I had a conversation with Jeff Smith, and in some of our conversations about homeless programs, and one of the things that came up with that was that he didn't really actually understand, after the years that we'd been working together, exactly what kind of the day-to-day processes were within the homeless program at the medical centers. I think we've all know Gary Kuna. He's presented at this meeting a few times as well, and he does an amazing job as far as actually showing out how they do the work and what it is as far as the training and engagement in that. But what I really want to try to do today is really touch on and give a good explanation of what's going on at the medical centers, what actually all of the different categories, processes, programs are, so that when you refer somebody to the VA, you kind of know what that is and you know where that's going. The other part of that, and this is kind of the background information that I'm hoping to build on throughout this, is that we're not able to accomplish this by ourselves as the VA. We've learned that with the homeless programs. It takes this collaboration, it takes this coordination of services with everybody. And so as I talk about what we're doing, I actually have always kind of been encouraged by hearing what it is you see that we're missing, because perhaps we can grow that in the VA, but maybe more importantly, it's something that we can grow together through a collaboration and coordination efforts. Kind of some of the basic numbers. We hear this all the time because this gets put up on websites and stuff. I always want to make sure that we touch on it. The number that doesn't get talked about that much is that for every successful suicide, there's 25 attempts. And this comes from CDC and SAMHSA. And so when you hear that there's 20 successful veteran suicide attempts or veteran suicides in a day, that means that there's 500 attempts every day. And that's where we need to begin with our work, right? Because we need to identify where those attempts are and get in front of that number too. And that's where we all need to work together on this. So, again, what are we wanting to do? So I'm going to today talk about the suicide prevention program itself, but also within the VA, we're pushing forward this whole health initiative. How do we build overall services within the VA? But how does that also then fit in with suicide prevention, right? Because as we build whole health, obviously mental health is part of that. So how do we reach out and touch some of those 500 that we haven't previously been touching? Also, the VA has a lot of different research projects going on, some of those right here in North Carolina, so I want to touch on those a little bit because I think that that's another way for us to get engaged and kind of figure out how we can continue to address this issue as a state. So, the suicide prevention programs within the VA. Obviously, every VA medical center has the program itself. We have a coordinator who has certain responsibilities, but then they have a group of case managers there as well who follow the individual veterans that have been identified, and I'll get into more specifics here in a bit. We also have the Veterans Crisis Line. To just touch on that, it's a 1-800 number. Veterans can call in family members can call in, friends can call in if they know that something's going on. And from that call, you talk to a live person who is immediately in touch with emergency services if needed, so that they can reach out to that veteran right away. And are you wanting me to give out the phone number as I say that? It's been up here a couple of times. But the other thing that it does is that it immediately links with the local VA medical center. So something gets an alert where that VA medical center, depending on how the veteran calls in, how they make the assessment of where that veteran is in the process, the VA Medical Center Suicide Prevention Program will have contact with that veteran within 24 working hours. Obviously, I think that's an issue over the weekends, and I certainly think that's something we need to work on. But we have that contact immediately. Wherever that veteran's calling in from, they're able to contact that person, and then the VA Medical Center reaches out, makes that assessment, makes that direct contact, works on getting them into the medical center and starting the whole process of engaging them into VA medical services. And then we have the general mental health clinics. A lot of veterans who are engaged in mental health, PTSD, depression, other serious mental illnesses, we have a screening process that's going on constantly in there, and they have that level of engagement. So the Suicide Prevention Coordinator, these are kind of their 5 primary tasks that they do. Tracking and reporting kind of tied into that. So as veterans are identified as having suicidal ideation, having issues come up, they immediately start tracking that person, making sure that they're making appointments. If they don't make the appointments, they reach out to that veteran to see what's going on. They have contact with the primary care providers and other treatment providers at the VA Medical Center to have that communication, to make sure that they're asking the right questions, making sure that they're following up on those issues. Whenever any of us go to see a doctor, it's usually a pretty rushed session. When I see my primary care provider, you go in for kind of a specific issue, you focus on that, and you move through. The role of the suicide prevention program is to make sure that this is always on the alert for those people, whether the veteran's bringing it up as an issue or not. So the program doesn't just work directly with the veteran, the program is also working with the clinicians to making sure that they're asking the right questions, making sure that they know which veterans are coming in. Another really important part that I think of is the outreach. We talked about what a great job Gary Kuna does, kind of what I'm doing now, getting this information out. But going out into the community as well. Going out to non-veteran specific entities. I was at a conference last week with a community in Virginia, and we often hear along suicide prevention ask the question. We're trying to destigmatize the issue. Well, I think another thing that's equally as important and something to think about is asking the questions, asking 2 questions, especially for our community partners here. Not just asking about suicidal ideation and if they're doing okay and if they're being depressed and all of those kind of issues, but also working with our partners to make sure that they're asking the issue of, are they veterans? Identifying that. So it's not just wanting to check in if you're a veteran or wanting to check in to see how somebody's doing. We need to make sure that we're doing both of those. So suicide prevention is everybody's issue. Kind of what I was going to. We need to increase our ability to reach out. We need to work on, lost track of my notes, sorry about that. But working together and sharing ideas. Again, from my work with homeless, and what I'm really hoping to bring with this is that there are amazing ideas in the communities, both within the larger mental health practitioner communities that we work with some, but just as far as grassroots projects, veteran-specific organizations, anything that we can do to increase our touch with this is kind of where we need to be going. Again, because we kind of put this in, I think we all hear about Operation Save. Again, just one of these processes of engaging people. I'm not reading through slides again because this goes up on websites. I like to put out as much information as I can in the process. And I think I'm always kind of limited on time when I start talking. One of the things that the VA does that's been new here in the last year, this is also run out of the suicide prevention program, it's called the Reach Vet Recovery Engagement Coordination for Health Programs. VA loves its acronyms. In short, what it is, it's an algorithm. So when you go into the VA, I think anymore with any kind of electronic records, as information gets put in based on the type of services given, based on the clinical reviews that are done, what ReachVet does is it's a computer program that's pulling that information. And then based on an algorithm that was created by somebody way smarter than me, it actually works at predicting who's going to have suicidal ideations. It looks at how do we reach that group that we don't have contact with, just because I see faces going up. So if somebody's coming in who is, let me back up a step. Whenever you go into the VA, there are probably 100 clinical reminders that get done. Everything from what's your diabetes situation to what are your vital signs to what's your income to homeless status, a wide range of things. And so it tries to use a method of identifying who's likely going to be at risk. And so for clinicians in the field, one of the things we talk about with working with suicidal ideation are what are the protective measures and risk measures that are in place. So this gets tracked electronically. And so for people who aren't already engaged, the suicide prevention program is reaching out to individuals, reaching out to them and saying, just checking in. Last time you were in, you reported having family issues. Last time you were in, you reported having financial issues. We're just calling to see how you're doing. Are you engaged with services? Do you know about what other resources are there? So it's that light touch, but it's that checking in. It's that process of seeing, is this something that's going to become an issue for this person moving forward as far as suicidal ideation and suicidal issues. Just started a year ago. I think that they're working on it, seeing how effective it is, seeing what it looks like. But it's a way for all of us to start thinking about how do we try to get ahead of this issue. Another thing that the VA has is something called primary care mental health integration. What this is it has mental health professionals embedded within primary care clinics. This is important for a couple of reasons. One is that it creates the warm handoff immediately when a primary care physician identifies that there's a mental health issue going on. It's not the process of a consult, waiting for an appointment, coming in, going to a different building. So they're just right there in the clinic, so you can touch them immediately. As an administrator, which working in the network, unfortunately, I am. The other thing it allows us to have that constant level of education going on with the primary care providers, with the nurses, with the clerks, with everybody in those primary care clinics where most veterans are getting their services. It gives us that ability to, again, be raising that issue of asking the question and having this on the front of everybody's mind so that we're not missing anybody along the way. So kind of switching gears, going a little bit to what Ms. Exner was talking about, the VA is moving towards a whole health initiative. And this is coming from looking at suicide prevention as a public health initiative. Kind of a change, moving away from that treatment model, but instead, how do we make this a topic that everybody is thinking about at all levels? And so great examples of that are things just as simple as putting fluoride in our water, right? A while back, we looked at and saw that there was this issue across the country with dental health. And all it took was just starting this process and making it part of everybody's life, everybody's conversation. Seatbelts. Just basic ideas that are basic health, but have, at the end, a significant impact on the quality of life of everybody and ensuring that people are as healthy as possible. So with Whole Health, we have an executive order. So this is VA-wide of having Whole Health implemented in every medical center by 2024, the VISN as well. But the idea behind this is just improving the health outcomes, reducing the cost, improving satisfaction. Again, I talked about building those protective barriers. When you're at that high risk situation of suicidal ideation, these are the things that keep people safe. But when you take a step back and look at what those are, they're things that make all of our lives better. They're the things that many of us take for granted. Family interactions, being engaged with faith-based organizations, having a stable income, having stable housing, having access to nutrition, having meaningful activities during the course of our day. We should be providing that for everybody who comes to the VA, or at least addressing it, identifying, talking to people about it, and giving them a path to accessing that. So just kind of a visual graphic for that as well. I think the important thing here, and I think it's something that is almost being taken granted for in most situations, but at the center of the circle is always the veteran, the patient, the client, the term, whatever term you want to use for that. But that's what leads the interactions that we have. And actual health care, clinical care, is just one of the circles that impact them. A lot of it is just creating plans and helping people move forward, making sure that they're thinking about it, and then making sure that they're having the resources to accomplish that in their lives. So, kind of going over that again, how does that work within a suicide prevention idea? One of the things I really want to talk about, and I can't remember if I have a slide on this or not. I don't. Good. Glad I looked at my notes. So within Vision 6, we actually have been identified as being a pilot project for how do we integrate whole health into the transitioning services. This actually goes a little bit to the person's question earlier on about TAPS, is how do we ensure that we're getting the VA whole health idea into the minds and into the knowledge of people being released from service before waiting for them to engage in the VA, before any of that, but putting it out, doing it as an education piece to current individuals in the military. The way the VA is doing this is that we're actually looking at doing this primarily through a peer support and a peer process. Again, there's only so much somebody like me can do coming up here in a suit and in my little VA tags and everything, but having somebody who's gone through the experience, the process of engaging in the VA, getting help from the VA in a way that's meaningful to their lives, that means much more to a service member who's being released than it does from someone like me. And Moses is standing up, so I'm going to try to speed this up a little bit. There we go. All right, good. 2 minutes and 2 projects. So the 2 things I really want to talk about quickly, the VA has a lot of different research projects in the world. 2 of them that are touching here in particular is that there's a faith-based organization process that's being initiated as far as providing training to community faith-based initiatives, going again over a lot of those 2 questions, making sure that they're knowing how to engage service members, and then making sure that they're knowing how to identify and refer into services. The other one that I find especially interesting here in North Carolina is a rural suicide prevention initiative. This is being copied after projects that are already in place in Colorado, Montana, and New Mexico. I think that an interesting thing, though, here in North Carolina is that's a different type of rural issue. When you look at those western states, the rural issue is really a geography. It's just so much space. North Carolina is almost the exact different in the sense that the space is smaller, but there's a significantly larger number of people. So in the western states, it's how do you reach these individuals because it's so sparse and far apart. The challenge we have here is that there's so many individuals who are still living in rural situations that how do we get the care out to them? So it's not reaching them as far as the time and the difficulty in finding them. Instead, it's about having enough resources to serve the number of rural individuals that we have. And so I'm really looking forward to working with that. We've already made contact actually with the chaplain out of the Durham VA and the research institute that's doing that, and hopefully this is something that we will be seeing initiated very soon. These are the contact information for all of the suicide prevention coordinators at the VA. All of this gets posted onto the website, so you can pull this and you can have access to it. As I see everybody desperately taking pictures and writing stuff down, I think it's very useful to have. And comments and questions, but I'm going to start off with a question. I've been working with the homeless program here for a while, presented on it many times, and I think that we've made amazing strides. Actually, coming up here in May, June, July, we're going to be presenting on it. But what and how that got accomplished was through the community collaborations that we have, and a lot of that has been based on a subcommittee of this task force, of this working group. It brings together the VA, state departments, and LMEs, and community providers, and it allows us and gives us a space to talk with it, when we can talk to the chair and get the real power behind it to make changes. And so one of the things I would like to ask is, why can you not have a subcommittee on suicide prevention and mental health? I would like to make that a request that I make to this group. Thank you.
I was fixing to ask a question.
Okay, I'm back.
Chris Knowlton, DAV, Department of North Carolina Commander. I heard you talk a lot about mental illness and suicide prevention and everything, but do you ever get on to the part about physical illness and suicide prevention? Because when you're in a lot of pain, you just get tired of living. Are you focusing on that any?
Absolutely. I think that that's part of the Whole Health initiative, is reaching out. I didn't touch on it here. We have a lot of stuff and a lot of training and collaborations within the VA with the pain clinics, and making sure that that's initiated into that as well, trying to review these issues with both the veterans and with the primary care providers that are working with them.
Can I talk to you privately after this session?
Absolutely. Yeah. Absolutely.